Good evening, everybody. Thank you very much, organizers, for inviting me for giving this lecture. Yeah, thanks. We all know that acute liver failure management in intensive care is a very challenging thing, and managing raised intracranial pressure it's very crucial because it makes a huge impact in the outcome of the patient. If a patient is there in the intensive care, there will be a lot of dilemmas and there will be a lot of questions. Commonly asked questions in intensive care is, patient with continuous seizures for the last 24 hours, will you transplant? Will you take this patient for transplant? Is there a definitive criteria for inserting an ICP bolt? Patient with fixed dilated pupils bilaterally, will you transplant? Will you go ahead with the transplant? And when will you say no for transplantation? If you think I'm going to answer for these questions in my lecture, you will be completely wrong, because I don't have the answer. Because it's a very rare problem. There is no randomized controlled trial anywhere in the literature. But I'm going to see what we could do. I can give some overview of what other people are doing right now. Incidence of intracranial tension is around 54% with the grade 3 or grade 4 encephalopathy. And if the patient is there in intensive care, the chance of developing ICT is further increases. But in recent data suggests that the incidence of ICT is coming down in the UK, probably early transplantation or better intensive care management. Surprisingly, it's more common in younger age group between 30 and 35. Maybe older age group, the brain is shrinking, there will be more space to accommodate raised ICT. In kids, probably it's very rare in infants. Again, we don't have enough data in India. If you look at the most common cause of acute liver failure in the UK and Western countries is paracetamol poisoning, everyone knows. In India, the most common cause is hepatitis A, B, and hepatitis E. The thing is, we don't know the incidence of ICT in these conditions, in hepatitis A and E, in virology. Looking at the clinical prognosis, hyperacute liver failure, the degree of ICH is very high compared to fulminant and subacute liver failure. But survival without liver transplantation is high in this hyperacute group. I just want to briefly go through the pathophysiology of the cerebral edema. We all know that there are three major contributors for development of hepatic encephalopathy. The first one is hyperammonemia. Second one is increased cerebral blood flow. Third one is increased inflammatory response. So our goal is to control all these three. We'll see how we are going to do it. So why hyperammonemia happens in acute liver failure? Basically, with the normal liver, there will be urea cycle. Normally, ammonia will be produced by the urease producing bacteria in the gut, which will be metabolized in the liver through the urea cycle into urea, which will be normally excreted in the urine. But in the absence of liver in acute liver failure, ammonia will not get converted into urea, so we will have hyperammonemia. This ammonia will cross the blood-brain barrier and enters into the astrocyte. That will cause hyperosmolarity inside the astrocyte, which will draw up more water inside. That will cause cerebral edema. If you look at the Monteau-Kelly doctrine, whenever there is a brain swelling, that the ICP will go up significantly. My previous speaker has made my job a little bit more easier by covering most of the intracranial pressure monitoring. I just want to stress upon few practical points in ICP bolting and jugular venous pressure monitoring. This is the King's College data. Actually, they suggest that arterial ammonia is a very important factor in determining whether the patient is going to develop hepatic encephalopathy or cerebral edema. They also suggest that not venous ammonia, it is arterial ammonia we should always do. Their data suggests that if the arterial ammonia is more than 200 micromoles per liter, there is increased instance of ICT. So we need to reduce the ammonia in this stage. They also found a few risk factors for the development of increased intracranial tension like age 30 to 35, in renal failure and vasopressor requirement. Indian data also suggest the same, but they got a value of more than 124 micromoles per liter of ammonia to cause significant intracranial tension. This is the data by Dr. Bhatia. This is the All India Institute of Medical Science data, where they have got 80 patients with a 52% of overall mortality. It's a non-transplant center. If you look at the area under the curve, it's 0.76. Again, this topic is covered, but I just want to say there are 4 ways we can monitor the intracranial pressure. One is through the Kaminer bolt in the subarachnoid space. Second one is intraventricular. Third one is intraparenchymal. Fourth one is epidural. The most commonly used method in acute liver failure is putting a bolt in the subarachnoid space. Epidural space data suggests that it's useless. Intraventricular, we don't normally prefer. There is no need to take spinal fluid out because the mechanism of cerebral edema is completely different. The risk of bleeding is 4 to 20%, but there is no randomized control trial for these things. But King's College criteria suggests that these are all the indication for putting an ICP bolt. The problem is, if a patient is there in the intensive care with acute liver failure, all of them will fit into this criteria. So you'll be putting bolt for all this patient. I don't think we can afford in Indian setting. So goals wise, ICP should be less than 25 millimeter of mercury. We should aim for the cerebral perfusion pressure of more than 60 millimeter of mercury. The most important bit about ICP monitoring is it's quite useful in the intraoperative management, not only in the pre-op management. Normally, after transplantation, the ICP will come down in 48 hours time. We are all worried about coagulopathy and bleeding while putting the ICP bolt. There is a way we can overcome it. If you give high volume FFP, like 15 ml per kg FFP, the INR will come down. But most often in these clinical conditions, we can't overload the patient. In that scenario, we can give 5 to 6 ml of FFP per kg of FFP, like 2 FFPs followed by 40 mics per kilogram of recombinant factor 7A. This is the data in, the numbers are not very high, but if you give the FFP followed by factor 7A, the INR will come down to normal within 30 minutes and you can insert the bolt. The chance of bleeding will be very less. Jugular venous bulb. I just wanted to share our experience with the jugular venous bulb oxygen saturation because we don't put bolting in all our patients. Our preferred method of choice for ICP monitoring is jugular venous bulb saturation monitor. We call as reverse jugular catheter. It's easy to introduce. We can monitor jugular venous saturation continuously, or we can take a sample. If you don't have that particular monitor, just put a single lumen central venous catheter, aspirate blood and send it to the VBG, venous blood gas, and we can see the saturation. So how do you interpret? If it's 55 to 75% is a normal jugular venous pressure oxygen saturation. If it's more than that, if it's 90 or 100%, that means there is cerebral hyperemia, which means there is a decreased cerebral metabolic rate or increased cerebral blood flow or increased arterial oxygen content. So we have to treat it immediately. If it's less than 50, this is also very bad because it may be due to increased ICP or decreased PaCO2, we have to treat it. There is a good correlation. If you see this graph, 62, if it stays between 60 to 80%, the intracranial pressure will be less than 20. It's a good correlation between the ICP and jugular venous oxygen saturation. If it's more than 80 or less than 60, ICP will be high. I'm not going to cover this bit. There are some studies going on with the cerebral microdialysis catheter. It's actually an online analysis of brain tissue biochemistry with the small microdialysis catheter, but it's not available in India yet, to my knowledge. I'm not sure it has come now, but it's quite costly. There are studies done with the 13 patients. They have measured glutamate and lactate in the brain tissues, and there is significant correlation between ICP and cerebral lactate. So how would you manage intracranial hypertension? We all know that, we all know about Westhaven criteria. Grade 1 and grade 2 encephalopathy, we seldom see ICP rise. In grade 3 and grade 4, it's 25 to 75% of a chance of developing ICT. Grade 1, grade 2 encephalopathy management is completely different from grade 3 and grade 4. It's all routine basic care in any intensive care. My point is, if you see a patient developing grade 1 or grade 2 encephalopathy, it's better to transfer these patients to the transplant centers early, because we do get patients brain dead when we receive the patients in a transplant center. Basic measures like 30-degree head-up position, lactulose, branched amino acids, or non-absorbable antibiotics, it's all routine. We should avoid sedation. Benzodiazepines should be avoided if there is grade 1 or grade 2 encephalopathy. Avoid stimulation. Broad-spectrum antibiotics with antifungal cover should be started as soon as possible. We all know that N-acetylcysteine is quite useful for paracetamol poisoning, but there are strong data which suggest N-acetylcysteine helps even in non-paracetamol poisoning. In grade 1 and grade 2 encephalopathy patient, the chance of survival is high with the NAC treatment. Grade 3 and grade 4 encephalopathy, the basic thing is we should look into the formula, like cerebral perfusion pressure is equivalent to mean arterial pressure minus intracranial pressure. The goal is CPP of more than 60 and ICP of less than 20 millimeter of mercury. Again, we have to intubate as early as possible if the patient goes into grade 3 encephalopathy. We should avoid all ICP surges like coughing, straining, suctioning. We should avoid all these things. Even sending the patient unnecessarily for a CT brain should be avoided. Hyperventilation helps temporarily, not continuously. If you think there is a rise of ICT, hyperventilate for half an hour, that will reduce, and we can go to the normocapnia. Adequate oxygenation, vasopressors to maintain adequate mean arterial pressure. Noradrenaline is the preferable choice. We can use telepressin. Recent data suggests that telepressin also equally good. Seizure control can be done with phenytoin. We have to treat antipyrexia. That's the most important bit. Any deterioration, if you see any pupillary abnormality, any persistent fits, bilateral fixed pupils, we should do a CT scan before thinking about transplantation, because that may be an absolute contraindication for transplantation. Primary management we have covered. Now we'll go to the secondary management. If you see a rise in ICP with the clinical parameters or ICP bolt or jugular venous saturation, the first choice should be mannitol. If the kidney functions are okay and the serum osmolarity is less than 320, we should try with mannitol, which will reduce intracranial pressure immediately. And there are a lot of strong data supports mannitol. The second choice will be hypertonic saline. 20 mL of 50% hypertonic saline over 20 minutes time will reduce the ICT. The possibility of developing dehydration and hyperosmolarity is high, but it's a good drug even if the patient is developing renal failure. Barbiturates I have already mentioned, but there is no strong support for barbiturate coma nowadays. Sedatives, propofol, fentanyl. Propofol low dose shouldn't cause propofol infusion syndrome, so we can use propofol even for kids of more than 2 years of age. Vasopressors I have already mentioned. Indomethacin, it's a quite useful drug as an anti-inflammatory, which will also reduce the level of ammonia. 25 milligram of IV boluses is quite useful. We'll go into therapeutic hypothermia. Rajiv Jalan of University College of London has done a lot of work on therapeutic hypothermia. The concept is, if you put the patient, if you reduce the temperature to 33 degrees Celsius, it will reduce the ammonia by decreasing the ammonia metabolism in the gut. This will also reduce brain glucose metabolism and CMRO2. This is also reduce the chance of inflammation. But the risk is the chance of infection rate is a bit on the higher side. And there are data which says if you cool the patient, the cerebral blood flow will come down in 4 to 6 hours time. In 24 hours time, it will come to almost normal. And the role of CVVH, continuous venous hemofiltration, in raised intracranial hypertension. If you see a serum ammonia of more than 150, and if the patient is developing hepatic encephalopathy, grade 3 coma, and if we are going to intubate, we would prefer to start CVVH early. It's not for renal failure, just to reduce hyperammonemia. And it has been strongly supported by King's College intensivist. And it's very useful in reducing the ICP. There are research which supports CVH is better than all a SPAD or MOS in reducing the hyperammonemia. MOS, we are going to have a lot of discussion tomorrow. There's a new drug called L-ornithine phenylacetate. It's maybe a game changer. A lot of research is going on in this drug. And the last thing is total hepatectomy and liver transplantation as two-stage procedure. If you are going to get a liver in 12 to 24 hours time, we can ship the patient to the theater, take the liver out, do a porto caval shunt, and the goal is we should remove the toxic liver. No liver in acute liver failure is better than bad one if you are going to get a new one. There are case reports which suggest in ALF cases more than 21 hours of long anhepatic phase, even with this patients are surviving. So ultimately, the goal is liver transplantation. That's the only treatment of choice. Again, brain death is the second most common cause of death in acute liver failure. This is the UNOS data with 1,457 patients. If you have a patient with a grade 3, grade 4 encephalopathy, with the body mass index of more than 30, with serum creatinine of more than 2, age of more than 50, I think we should think twice before taking this patient for liver transplantation. There are relative contraindications. We couldn't find out any strong data. Experts like Jules Venton from King's College and David Kramer from Mayo Clinic, they suggest that if you have a patient with the pupillary dilated pupils for more than 2 hours, better not to transplant. So to conclude, take a message: arterial ammonia, do it early. If it's more than 150, start CVH. If the patient is developing grade 3 or grade 4 encephalopathy. ICP monitoring wise, there is no better neurological outcome ever been documented with any of the ICP monitoring devices, but we need something to treat it. ICP Bolt, if you are comfortable, that will be the preferable choice. If you are not comfortable, go with the jugular bulb venous oxygen saturation. That's what we normally do. Thank you very much.
Thank you, Dr. Ilan Kumaran. I have one comment and one question. A lot of these patients with acute liver failure are actually more irritable as opposed to those with chronic liver disease who tend to become more drowsy. And I have had a couple of patients, young individuals with viral hepatitis and ALF, who've responded very well to low-dose propofol infusion. And if you give it at, say, 2 to 4 milligrams per hour and start off and titrate it for the next 48 to 72 hours, many of them do quite well. Any comments or?
In our unit or most of the transplant centers in grade 1 or grade 2 encephalopathy, we'll try to avoid giving any sedation if the patient is not intubated. We strongly feel it will cause more problem than probably it's individual preference, but we will try to avoid. Even data suggests we should avoid all sedation with the grade 1 or grade 2 encephalopathy.
It keeps the ICP under control if you have these patients who
I think if you think the ICP has raised, I think better to intubate early, because that will benefit the patient. Because we feel grade 1 and grade 2 encephalopathy, the ICT should not go up. If the patient develops irritability with grade 1 encephalopathy, we rule out all other causes like a metabolic problem or bleeding or any other things. I think I wouldn't probably give any sedation with the grade 1 encephalopathy.
Any experience from the senior consultants about low-dose propofol infusions in ALF? Okay, the other question I had was regarding prophylactic anti-epileptics. Is there a role, or has it been proven, or it should be given or should not be given?
Actually, there is no role for prophylactic phenytoin. In some centers, they do give. But that's absolutely, you're absolutely right. We don't normally give a prophylactic phenytoin unless otherwise the patient shows any signs of seizure activity. We don't normally give. But in some centers, they routinely use. But there is no strong evidence to support it.
Any other question from the audience? Yeah, last one.
In grade 1 and 2 encephalopathy stages, we face the patient sometimes become very much highly irritable. How to control it? In case of emergency, what sedative you will prefer to give? And in your setup, what you give?
Yeah, probably we will definitely avoid benzodiazepines. we will definitely avoid propofol or any opioids. We would prefer to give a little bit of haloperidol because it wouldn't increase the chance of sedation, and it wouldn't affect the respiratory, it wouldn't cause respiratory depression. So haloperidol will be more safer. I'm not sure somebody will object to using haloperidol, but we are very comfortable using haloperidol if the patient is more irritable in grade 1 with grade 1 and grade 2 encephalopathy.
Okay, thanks. Thank you, Dr. Kumaran,
Thank you much.
for a very educative talk. There is slight change in the